Hello, and welcome back to week 3 of our cardiac education series. Today we're going to review ventricular rhythms. So just a little bit of an overview. Our ventricular rhythms occur when impulses begin in the ventricles. They start outside of the SA node, or the SA node fails to fire the electrical impulse. QRS complexes measure 0.12, so a fraction of a second, and the ventricles are the heart's least efficient pacemaker. So it's kind of that last-ditch effort to keep the heart pumping, keep the blood flowing, maintain oxygen levels in the blood. It's, like I said, that last-ditch effort. Premature ventricular contractions, or PVCs, are an ectopic beat or a disturbance in a regular pattern. Think irritability. I try to compare stuff with cardiac, with the heart muscle to the uterus, because I can relate to that. So when you have uterine irritability versus cardiac irritability, the heartbeat occurs earlier than is expected. Your QRS will look different from the others. Your T wave often is in the opposite direction of your QRS. So if your QRS is going up, your T wave will point down, and vice versa. Causes of premature ventricular contractions: hypoxia, anxiety, exercise, aka labor. That's a lot of hard work, people. So they're working hard. CHF, heart failure, ischemia, digoxin, toxicity, electrolyte imbalance, alcohol, ETOH, tobacco, caffeine, and an acid-base imbalance. It can be perfectly normal and not have any detrimental effects to the patient. Or the patient may report feeling like their heart is skipping beats, or that they're feeling extra heartbeats. So when we break down our PVCs, our rate is generally normal. The rhythm is regular with those premature beats. Your P wave, there will be none with the PVC, but your other QRS complexes will have normal P waves. Your PR interval, there's none associated with your PVC. Your QRS will be greater than 0.12 second, and your T wave will be in the opposite direction. Some fun facts about PVCs. PVCs that are identical are called uniform. So think the same, look the same is how I remember that. And PVCs that are different are considered multiform or multifocal, which is everyone thinking differently, so it's going to look different. R on T phenomenon is when PVCs fall on the T wave of the previous cardiac cycle. So it didn't have that moment of rest period. It already started back up again. This could trigger ventricular tachycardia or ventricular fibrillation. So definitely something we want to be aware of, because we know that those are shockable rhythms potentially, and can be life-threatening. So definitely important to know those things. So some more fun facts. You can have PVCs in bigeminy, trigeminy, or quadriminy. I'm not sure if I'm pronouncing that right, but close enough. You get the idea. So a bigeminy is one normal beat and one PVC repeatedly in a uniform pattern. So bi is Latin origin, meaning two. I think most of us know that. And geminis is Latin, meaning twin, which I thought was kind of neat. Fun facts. So your trigemini is going to be 2 normal beats and 1 PVC. So every 3 beats or every third beat, you'll have that PVC. So again, tri, Latin for 3, geminis meaning twin. So every 3 beats, you have the 2 normal and then the third one, the PVC. And as you can imagine, quadrigemini is exactly that, but 4. So every third beat is normal, and then your fourth beat has the PVC. So I really like this picture that kind of breaks it down for us. So you can see the top one is your couplet, which then leads into a little run there of ventricular tachycardia. And then the middle one is your ventricular bigeminy. So you can see the 1 normal beat followed by the 1 PVC. And then that bottom strip is your trigeminy. So every 2 beats, and then your third one is the PVC. Ventricular escape beats originate in the ventricle. They have a wide QRS because your impulse originates in the ventricle. It skips the SA node completely, and it occurs late in the cardiac cycle. It is a protective mechanism of the heart, which prevents the heart rate from slowing down even further than what it would without this mechanism in place. Some causes include MI, digoxin, metabolic imbalance, and your patient may exhibit hypotension, disorientation, syncope, and loss of consciousness. So when we break down our ventricular escape beats, our rate depends on the underlying rhythm. Our rhythm can be irregular. Your ventricular escape beats happen after expected sinus beats. So you may see sinus rhythm with irregularities. Your P wave, there's none associated with the escape, right? Because remember, it skips that SA node process that starts your cardiac cycle. And again, if you don't have a P wave, you can't have a PR interval. Your QRS is going to be greater than 0.12 second for the escape beat. And your T wave will go in the opposite direction of your QRS because the electrical impulse is starting in a different location. Idioventricular rhythms. Your SA node and your AV junction fail to fire or fire at a rate less than your ventricular rate. So your ventriculars are pumping normally, and your SA node and your AV junction are kind of doing their own thing. Your ventricles will then respond by initiating their own impulses because they're trying to keep up the heart rate to maintain homeostasis. It avoids your normal conduction pathways. So when we're looking at these beats, your ventricular rate is going to be between 20 and 40. Your rhythm will be regular, but your ventricular rate will not be visible. You will not have a P wave, and if you don't have a P wave, you won't have a PR interval. Your QRS will be greater than 0.12 second, and your T wave, again, is in the opposite direction of your QRS because those impulses are coming from different locations. And then we have our accelerated idioventricular rhythm, which is an idioventricular rhythm, but your heart rate is 50 to 100 versus the 40 that we talked about before. Wasn't that easy? So here's a picture of what an idioventricular rhythm might look like on an EKG strip for a little visual presentation there. Next up on our list, we have ventricular tachycardia. That's when you have 3 or more PVCs at a rate greater than 100 beats per minute. You'll have a wide QRS. It will be, if it's non-sustained, that means it lasts less than 30 seconds. So it's just a couple of beats and then it goes away. If it's sustained, the definition is that it lasts greater than 30 seconds. And emergency, right? That should send off your radar, your red flags. This is not okay. So your step 1 is, if you see that on your telemonitor, you should be running to your room, laying eyes on your patient, and we're going to want to check for a pulse. So you can have ventricular tachycardia with a pulse, which is one algorithm and treatment pathway, or tachycardia without a pulse, which is a whole nother ball game. We would follow a whole nother treatment pathway for that. So that's our number 1 step, is we need to check to see if they have a pulse. If they're ventricular tachycardia with a pulse, that's more of a rapid response type situation. We need to get the ball rolling and take care of this patient urgently. And obviously, if we check them and they do not have a pulse, then at that point it would be a code blue situation. We would follow our ACLS algorithm. So some causes of ventricular tachycardia. MI is one, acid-base abnormalities, electrolyte imbalances, hypoxia, CNS stimulants, cocaine, amphetamines, anything of that nature. And some of our cardiac drugs can actually cause this as well. So we're thinking DIG, quinidine, procanamide, all those heavy hitter antiarrhythmic cardiac medications, which is a little ironic. We're giving antiarrhythmics, which then cause an arrhythmia. So break it down, make it simple. Our rate is going to look like 100 to 250 beats per minute. That's relatively fast. If your patient has a pulse and is still alert, they might say that they feel like their chest is pounding, which stands to reason, right? If your heart is pounding at 250 beats a minute, you're probably going to feel it. It can be regular or irregular. Your P wave may be present or it may be absent, and there is no relationship whatsoever to your QRS complex. With your PR interval, there is none, as you'll see in the visual I have in just a second, and your QRS complex is going to be the same, greater than 0.12 seconds. So here's our little visual here of ventricular tachycardia, or VTAC. So this one looks pretty regular. You can see your QRS, there's no P waves there, and that heart is just pounding away. So we have a form of VTAC, which is polymorphic ventricular tachycardia, which is when we have VTAC, but our QRS complexes have more than one shape. So they don't look as pretty as that visual I just showed. And in addition to that, you can have torsades, which is a prolonged QT interval, and it actually looks like it will twist and spiral around your isoelectric line, which is like where your baseline would sit. So that is really fun and interesting too when you get to see that. And some causes of those things include electrolyte imbalance, bulimia, so eating disorder, anorexia. And if you think about it, right, they're going to be electrolyte imbalanced. If they have some sort of eating disorder, they're not absorbing nutrients and electrolytes the way that they should be. So that makes sense. It can be drug-induced, so your cyclic antidepressants, phenothiazines, quinidine, or procanamide can cause this as well. When we're looking at our breakdown, our ventricular rate is going to be 150 to 250 beats per minute. Your rhythm can be regular or irregular. There isn't going to be a P wave, and then therefore you don't have a PR interval. Your QRS will be greater than 0.12 second with alterations in your amplitude, shape, and width. So the top photo here, you can see the polymorphic ventricular tachycardia, or PVT. It looks messy, it looks chaotic. Your QRS are different shapes, sizes, and then the torsades looks like the polymorphic V tac, but you can see how the shape makes it look like a spiral. It is bigger, then smaller, then bigger, then smaller. So it's a little bit more uniform, yet still chaotic, if that makes sense. All right, next up on our list, we have ventricular fibrillation, or VFib. So this is when many different foci in the ventricles are fibrillating or contracting in a chaotic manner. The heart is quivering more so than it is pumping. So if it's not pumping, right, remember that blood flow is not happening, and your body is not getting oxygen. It's not getting blood, it's not getting nutrients, all the things that our blood does for us. Again, this is an emergency, right? So if we're noticing this, step one is run to your room and check for a pulse, listen for breathing, monitor your patient. If you find that there's no pulse, there's no breathing, we're going to start a code blue and follow our ACLS algorithms. What causes VFib? A lot of things. Acute MI can be one. Untreated VTAC can then lead to VFib. So you know how I always say don't make a bigger problem than what you start with. If you don't recognize VFib, it can then turn into VTAC, or vice versa. If you have VTAC and you don't do anything about it, it can then lead to VFib. Electrolyte imbalances, acid-base imbalances, hypothermia, RNT phenomenons, and electrocution. Fortunately, we don't see too many pregnant patients being electrocuted, but you never know. Breakdown. So let's talk about that. Your rate is going to be unable to determine. Your rhythm is irregular and chaotic. You'll see this in a visual in just a second. Your P wave is not discernible. Your PR interval is not discernible. And then therefore your QRS is not discernible. So everything just looks like a bunch of mess, essentially. And this is an EKG image of that. So you can see how it just looks like a bunch of little squiggly lines. Everything's kind of quivering, and it doesn't seem to make much sense. We don't really know where it's going. We don't know what it's doing. Asystole. So that's a lot of fun. It's the absence of electrical activity. Your patient has no pulse, aka it is also known as a flat line, because on your EKG or on your telemetry, you will see no activity whatsoever, or you may see just like little teeny tiny waves, but they will not look like cardiac rhythms or any part of the cardiac cycle. Some causes of this, cardiac damage, right? Cardiac damage to the cardiac muscle, ventricular aneurysm, so that's interesting, respiratory failure, shock, or any sort of traumatic cardiac arrest. And here's your visual. So I picked this one on purpose because it is not completely 100% flat. You won't see a completely straight line like somebody took a ruler and just drew a line across your EKG strip. There is a little bit of movement, a little bit of motion, not enough for us to say, oh yeah, they have any sort of electrical activity happening in their heart. Pulseless electrical activity, or PEA, is a rhythm that appears to be sinus upon monitoring. So whether they're on telemetry, they have an EKG that's taking place, the heart has no beat, no contraction, aka patient does not have a pulse, right? No beating, no pulse, no blood flow, no oxygen. Some causes, MI, myocardial infarction, tension pneumothorax, cardiac tamponade, hypovolemia, right? If you don't have volume, your heart's not going to pump. Hypoxemia, lack of oxygen in the blood. Hyperkalemia, again, going back to those electrolytes. Hypothermia, pulmonary embolus, calcium channel blocker overdose, right? If we overload the system with calcium, what's going to happen? Your heart's going to stop pumping. Acidosis, DIG toxicity, and cyclic antidepressants. So lots of different reasons why a patient could potentially be in PEA. I really like this visual. I was trying to be funny, even though it's not funny, it's not something to joke about, because you could see this on your telemetry monitor and you think everything's fine, I'm busy, I haven't checked on my patient, but I can see on the monitor that they've got a pulse, everything's good. And then you go in the room and find out, no, you really have a dumpster fire and your patient is not good, and you need to act quickly. So just because you see something on the monitor doesn't necessarily mean that it's right. So that's kind of my point to drive home, is we don't want to nurse our monitors. We want to nurse our patients. Always evaluate them, always check on them. We stress the importance of our hourly visits, making sure that somebody's laying eyes on them. So that wraps up my presentation on our ventricular rhythms, week 3 of our cardiac review. Feel free to reach out if you have any questions or any suggestions for education you'd like to see in the future. Thank you for watching. Bye.